Our next speaker tonight is Dr. Joe Kosterich from Little Green Pharma.
All right, thanks very much, Charlene, and thanks, I echo Paul's sentiments for coming out tonight. Let's see if we can get this thing to work. There we go. All right, necessarily, I'm not going to provide any specific medical advice, so please don't ask me for a script afterwards. And yes, I am a clinical advisor to a company called Little Green Pharma, which is a medicinal cannabis company, so that is my declared interest as well. It is confusing. There's certainly at the moment more questions than answers when it comes to medicinal cannabis, but that's not of itself a problem because unless we ask questions, we're never going to find answers. And compared to probably 2 years ago in this country, questions are actually being asked and more people are starting to ask questions, which in turn will lead us to find more answers, and it'll probably take us down some interesting pathways. And it is a little bit complicated, and I just want to touch on this very briefly because Paul's covered it very well, that typically with a pharmaceutical agent we have one molecule or compound which is typically patented and it's designed to have a particular effect. When we're talking about medicinal cannabis, we're talking about a number of bioactive substances, the cannabidiol, the THC, the terpenes, and it's very likely that it's not one of the above, but a combination that may be having the effect. And this is a little bit outside the normal thinking for medical practice, where we try to reduce everything down to one active component. So that does do the heads in of doctors. And also Paul touched very well on the endocannabinoid system, and I did take this slide from a presentation I was very fortunate to attend last year. In fact, I chaired the session in Melbourne that Ian Brighthope presented at, and this is just outlining some of the places where we find cannabinoid receptors. So it's pretty much, when you look at that through the whole body, particularly the one that's interesting, I think, watch this space, is quite a lot in the immune system. And at the moment there's a lot of talk and speculation about what might be the effects of medicinal cannabis in treating cancer, and if that's to go forwards and we're to make some discoveries, it will probably be through its effect in the immune system. But the bigger ones at the moment that we're more familiar with are through the central nervous system. And there's a lot of talk about we need evidence in what we do, and this is a little bit of an aside, but it's fascinating sometimes with doctors that when there's something new, they all scream that they want evidence. When it turns out that what they're doing might not have as much evidence behind it as they thought, they all tend to go very quiet. Today, on the back of a report out of the Lancet, it turns out in this country that we are spending $4.8 billion on treatments for back pain that don't work. That includes surgeries, opioid medications, a whole lot of treatments that get paid for, and a lot of it by you and me as taxpayers through the government, and there's no evidence for it. Yoga, there's evidence for it, but try claiming that back from your insurer and see how you go. So when we hear doctors saying they want evidence, yeah, that's fine until the evidence doesn't suit them or what they're doing doesn't work. So sometimes a bit of a double standard here. There is good evidence or reasonable evidence for use in intractable epilepsy, and I think, as Paul said, benefits have to outweigh risks. Obviously in children under 18 and in anybody who's being treated, benefits need to outweigh risks. I think that's a basic tenet of medicine. Chronic pain in adults, and again, just yesterday on one of the medical news sites, there was a case write-up of a doctor from Victoria who's prescribed for a person who had chronic neck pain, and she described the very positive results she had with that in treating this person who had failed where a lot of other treatments had failed. Spasticity symptoms in multiple sclerosis, and again this is very much about quality of life and improving the life of people with multiple sclerosis. I don't think anybody's saying that medicinal cannabis is a cure for multiple sclerosis, but it's very much about improving symptoms and quality of life. And chemotherapy induced nausea in people who are being treated for cancer. And just to touch on that, evidence has been published. The New England Journal of Medicine is a very mainstream medical publication. It's up there with the Lancet and the BMJ, so it really is what we call grade 1 evidence, and that was published last year. There's some evidence in other areas, post-traumatic stress disorder, anxiety, improving sleep and fibromyalgia. There's other areas where people are looking at. I'm fielding a lot of inquiries at the moment. People are asking about Parkinson's. There isn't really much evidence to go on, and it's certainly not a use that can be or can get any approval in Australia as we stand here at the moment. And there are future possibilities. So where might we be going with this? Yeah, perhaps Parkinson's, maybe motor neurone disease. There's some researchers in America who are very interested in medicinal cannabis as a treatment for addictions, which is quite fascinating when you think about it, because most of our current thinking says use of cannabis is addictive, and research before autoimmune conditions. So it's a very fluid and changing space, and it is going to turn some of our conventional thinking on its head. And this is a systematic review of medical cannabinoids. It was actually published just last month in Canadian Family Physician. And they looked at 1,085 articles. And that immediately says a lot to me that there are 1,085 articles out there. So when you hear people say, there is no evidence, there have been no papers, this is a review of 1,085. And that's not all of them. This was a Canadian review. And again, looking at pain, spasticity, nausea, and not necessarily adverse events. And the fact that there may be adverse events doesn't mean that something can't be used. There is not a single medication, the humble paracetamol included, that doesn't potentially have side effects. We always need to weigh up the benefits against the risks. And the fact that adverse events or side effects may occur means that we might need to reduce the dose or stop it in those people, but it doesn't mean that it can't be used. And this conclusion, and you probably can read it out, there is reasonable evidence that cannabinoids improve nausea and vomiting after chemotherapy, so that confirmed that. Improve spasticity, and we spoke about that a moment ago, primarily in multiple sclerosis, maybe in other conditions. Some uncertainty about whether cannabinoids improve pain. Yeah, look, I think if you speak to people who've had chronic pain and have used medicinal cannabis, have got improvement, they might have a different point of view to that. But that's what these reviews found, and fair enough, they've published it. And look, there are adverse events, and we need to be wary of that and aware of them. But it doesn't necessarily mean that either A, it can't be used, or that those events can't be worked around. But necessarily, that's sometimes how people feel. It's like, well, where does all this leave me? How am I to advance with this? And so these are just some of the side effects. I'll go through this very quickly. You can read them out because Paul has sort of touched on that. None of these things are insurmountable, and they can also wear off. This is a nice simple process for doctors to prescribe cannabis in Australia. It's a really good resource, consultation with the patient, TGA access, you've got step 2A, 2B, it's an algorithm. It is quite difficult, and this is to get through TGA, and then you have different state regulations. Now, when we had the sessions last year, and I was fortunate to speak at the corresponding one in September, since then there has been progress. Victoria now essentially has put its Medicinal Cannabis Act on hold. They're reviewing it, and it likely, if it comes back, it'll be if the TGA, which is a federal instrumentality, has approved prescription, then they will rubber stamp it. New South Wales is effectively doing the same thing. Unfortunately, WA is dragging its feet a little bit. We still have a panel system with somewhere around 15 doctors who meet every now and again on a Friday at 5 o'clock, as I'm given to understand, because it's the only time everybody can get together, to look at applications. It's not the best system that we could possibly have, and hopefully some pressure will be brought to bear on the Health Minister to bring us up to date. I mean, we really don't want to be behind New South Wales and Victoria if it can be at all avoided. So again, it's bad enough you're sort of thumping your head, and then really you've looked at that as a doctor, and this is probably how you're going to end up feeling, and it's not surprising. Apologies to people here last time. I have used that slide before, but I think it's such a good one. And then it does get a little bit more complicated, because normally if you want to prescribe a medication as a doctor, it's going to come in certain formulations. It'll be 2 milligrams, 5 milligrams, 10 milligrams. There might be a few variations. They'll have prescription information that says it's prescribed once a day or twice a day. There might be a course. It might be for a week, or it might be a month, or whatever. It's not like that with medicinal cannabis. It really is sort of find your own way, make a start low, go slow. So there are different formulations or different percentages of THC to CBD. How do the terpenes fit into that? What is the dose? How many times a day? How long should we treat it for? Do we need to change the ratios? It's not it is not analogous to any other form of prescription. All can be learnt and gotten around, but for doctors who are used to, a more binary, straightforward way of prescribing, it is one more complication, not insurmountable, but it is another complication. And then we get into, if we've decided we're going to use it and we figured out what the dose might be, are we going oral? And this could be an oil or a capsule, or it could be what we call sublingual, which sort of sits in the mouth rather than getting swallowed. Creams are coming on, and inhaled, so it's not necessarily smoked. Inhaled could be some of those devices that Paul showed. It could be vaped. There might be other ways of getting it in via that mechanism. So we have all of these variations rather than a standardised formulation. That's good because it now enables us to better work towards what's going to work for the individual, but the difficulty is that it's a different way of thinking. And of course, we've got a lot of calls for research, which is good. The other useful move since we spoke last time is the Royal Australian College of GPs has moved to a position of saying it is too hard for GPs to prescribe, and they want a national framework to make it a little bit easier, and that would be a good thing. Unfortunately, the College of Physicians, there was a guy on the ABC a few weeks ago said we need to hit the pause button. I'm sorry, we haven't actually started seriously. We're not going at breakneck speed. I'm not sure we need to hit the pause button. And really, this is the standard way that medical research goes, which has this hierarchy based on the idea that we want to find out whether medications work and whether they're safe, and it goes all the way up to systematic reviews. And that's a sort of old way of looking at it. A newer way, and I have borrowed this, and you'll see for those of you of a certain age, they'll remember this, we've got something old, we've got something new, we've got something borrowed, because this is borrowed from BANT, which is a lifestyle group. And they're really saying that we need to turn this on its head, and what really matters, and there is talk about precision medicine, which is saying we don't have one size fits all. It's not the same milligrams, the same times a day for every person. We want to individualise our treatments to what works best for the person. And that comes to a patient-centred N=1 type approach. Now, what they call N=1 trials can be dismissed as anecdotal in the old system, but in the new system, it's actually the pinnacle because it's saying we really want to find out what works for this person or for you as an individual. And just to throw it in, I've got something blue. For those, this has gone right over everybody's head. Anybody remember something old, something new, something borrowed, something blue? Does that ring a bell? Am I too old? Sorry. That was what you meant to bring to a wedding. And look, after we get all this and it's all happening, we'll all be jumping for joy as well. So there are considerations, which is access. We've touched about it. We've got 2 levels of government at the moment, and really there's no need for that. It is duplication. We do one thing well in this country, it's duplication. Concerns about diversion and illicit use. You know what? If you want to get high, it ain't going to happen with a bottle of medicinal cannabis, and it's going to cost you a lot more than growing something in your backyard. But look, there are genuine concerns in the public and through the medical profession, and those do need to be addressed, and it's no use shouting at people. We need to educate people and take them along with us. So again, to get back to precision medicine, and this is again one of the things with the research, and I've also borrowed this one. You can sort of see you sort of observe natural phenomena, like maybe medicinal cannabis works. You formulate a hypothesis, away you go, you test it, and you keep going. These days, you generate a theory based on government grants and tell the government what it wants to hear. Unfortunately, that's not quite as out there as it might appear. And I want to finish second last with a quote, and I will read this out, because this is from 500 years ago. 500 years ago. And this really applies to people like Paul and Adam and Blaze from the Medicinal Cannabis Council and Ross Walker, and people who've been pioneers. And it ought to be remembered that there is nothing more difficult to take in hand, more perilous to conduct, or more uncertain in its success than to take the lead in the introduction of a new order of things. Because the innovator has for enemies all those who have done well under the old conditions, and there's a lot of them, $4.8 billion, for example, and lukewarm defenders in those who may do well under the new. This coolness arises partly from fear of the opponents who have the laws on their side, and we see that, and partly from the incredulity of men who do not readily believe in new things until they've had a long experience of them, which is human nature. Thus it happens that whenever those who are hostile have the opportunity to attack, they do it, like partisans, whilst the others defend lukewarmly in such wise that the prince is endangered along with them. And that's from Machiavelli in 1513, and it's amazing how really apt that is still today for those who are trying to advance the cause of medicinal cannabis. But the supporters are getting louder, and the defence is certainly much less lukewarm. So what do we need? Appropriate regulation and access? Absolutely. Education and support for health professions, politicians, bureaucrats in particular, they're often worse than the pollies, the public. We need open minds, collectively and generally, and we need perseverance. Thank you very much.